So thank you again to Amrita and to the rest of the organisers for inviting me to speak to you today. And as Amrita's alluded to, I'm hoping to give you some context and insights about how we might take practical steps to harness the value arising out of health data. And I don't think anybody who's listening would argue if health data has value, and we've heard practical examples of how that might be applied in terms of solutions that are deployed into care. But what amount of value that might have, whether financially, which some estimate as much as 9.6 billion a year, and of what kinds of value, and then who should be the beneficiary of that value, are all up for debate. And I think if there was an easy answer to this, people would have found it already, in the same way that I think we might have reached a common understanding of a metaphor for the data itself. So as oil or wine, suggesting economic value, as infrastructure that is therefore an enabler but not directly valuable in and of itself, and as an asset potentially to be sweated. So in the absence of consensus on how we might describe health data or how we might approach valuation, and being in the position of trying to support the harnessing of that health data for new insights in medical imaging and AI, we were acting as a broker for collection and use by NHS, academic and commercial parties. And we were really looking for something solid to help us navigate the deals we were directly involved in, and considering the different stakeholder needs and perspectives in doing that piece of work. So why do I think that's going to be of interest to you and the audience, particularly for the radiologists and radiographers? As you'll be acutely aware, there are workforce shortages facing the radiology workforce, which are as 34% nationally and rising to as much as 44% regionally, with that expected to be the sort of national figure within the next 4 years. And this situation was compounded by the pandemic and is now increasing further with the elective backlog of cases in cancer and other disease indications as a consequence of the pandemic. You counterbalance that with the goal to not only deliver on the care of keeping current, but enhance innovation and deliver excellent clinical care. The system really is unsustainable and will fall over. You couple that with cross-cutting themes of the ageing population, health inequalities and the levelling up agenda, and then combine that with the growth in digital healthcare investments. We're really being pushed to find a way to do more and better across this backdrop. And AI has a potential significant role to play in this, improving patient care, and would obviously be a fundamental goal of the use of health data. So we know we should be using the data better, and we know that there's potential, and we've heard examples from use cases over the last 2 days. So why is AI not already embedded and supporting these challenges more? I think we've heard examples again over the last 2 days about some aspects of how the use of data is complex. We've heard little bits around DPIAs, ethics, consents, the legal landscape, the concepts around who owns the data itself, the fact that we're sitting in a global landscape as well, which has been evolving as a consequence of Brexit, and different perceptions on how health data should be managed between different global players. The US and China viewing things potentially quite differently than the UK and European systems. And then on a micro level within individual NHS trusts, they've been a driver of some of how these resources and data have been used, and brokering specific deals that benefit their local interests, but potentially create situations where you're making agreements with little precedence of what a good deal might look like. And that's been addressed partly through work through the groups like Reform and Elihar, which is work looking at how one might assess the value of data, and seeing this as being part of a data value chain where data is generated and then potential value is realised, and that this flows through different stakeholders in the system, generating that data and then generating new insights which can drive further value, which you would hope would form a virtuous circle back to improving care and better outcomes. But there is still a sense that the value of the data itself sits in the eye of the beholder. So where you sit within these systems impacts on how valuable you might think the data is. Ellie and Reform's work sits within a broader landscape of advice and guidance that the UK government has also been involved in. And we've seen an increasing range of reports and policy pieces around how one might think about how one uses data, with again a particular focus on the legal and ethical components, but starting to have increasing focus on commercialisation and including the establishment of the new Centre for Improving Data Collaboration sat within NHSX. So this provides some of the broader context and guidance, but still, what does this mean practically if you're trying to do deals on the ground? And this is the position NCIMI found itself in, that the landscape was shifting, that we were trying to engage multiple stakeholders in deals and didn't know how to apply those different principles and guides to actually drive good deals in practice. So what is NCIMI and why does this matter to us? We are a consortium, as Amrita mentioned, of 14 NHS trusts, academic partners and commercial entities supported through Innovate UK, focused on transforming healthcare through AI to improve diagnosis and treatment for patients, and making sure we're doing that in a collaborative ecosystem-based approach. We've supporting activity across a range of different clinical use cases and pulling data from the large diverse geography of hospitals to our central data bank in Oxford to support then AI development, validation and deployment, so trying to make the process easier at all steps of the pipeline. But to enable that, obviously we're dealing with data deals and the sharing of data from NHS trusts to commercial parties, and trying to understand what was the best way to enable us to actually do that work well and ensure that we were structuring deals that were going to generate value for all partners. To support us with that work, we engaged the charity Future Care Capital, and they were introduced to us through Anne-Marie Naylor, and we've been working to try and help us develop a framework for assessing the deals we were doing and how we should best approach those. And this was something we initiated in the back of 2019 when the then Code of Conduct had been published, but there were a few practical public applications of how one applied this and actually tested this in real world deals. As we began to explore the goals of how we might value data and look at making sure there was value for all parties, we were looking with our stakeholders in more detail when the pandemic hit, and that obviously produced changes not only in our ability to engage with our consultees, but also introduced new variations in terms of information governance, the coping notices around access to health data, and therefore we had to pivot slightly to focus more on the live deals we were engaged in and think about how we could use those real world examples to inform the negotiations we were involved in. So Brexit as well is coming up and been altering some of those landscapes, which has made trying to pin those deal terms down, execute them, and then support the partners coming together to do the pieces of work has been that we're trying to work in a rapid changing environment. So we would like to propose that there's a pause on further evolution of the national policy guidance to allow some of that innovation to bed in and to allow the stakeholders to actually deliver where they've got some framework at least of what the rules of the road are, before we try and shift the sands even further. So whilst we were trying to work within this space, we've been focusing, as I say, on trying to realise value for all stakeholders. What we did initially was looking at a legal exploration of the landscape and published a report on that pre-COPE and pre-Brexit, but with a range of questions for those engaged in this environment as to how to think about they were using data, particularly in commercial partnership-based work. We then engaged in a range of qualitative research, working with our different stakeholders who range from NHS Trust full-time clinicians through to entrepreneurial CEO spin-ups that also have NHS roles, through to large multinationals, as well as CFOs and chiefs of R&D and patient groups. And in exploring some of the deals we were doing, what became apparent is that our experience was certainly not of simple bi-party negotiations, but there were pooled interests across the stakeholders, and that the value was going to be arising and then benefiting back to a number of those. And so again, we'd like to suggest that this model of multi-stakeholder deal arrangements is factored into further guidance for those that are making deals in the future. Our experience as well, working through where data value arises, made us reflect on the focus predominantly currently in the early stages of the data value chain, which you saw earlier, with particular interests around the IG ethics, DPIAs around data sharing early on in these projects' life cycles, and that really there is an asymmetry in the power of deal partners at that early stage, And we should see more of a focus on those latter stage components of the value chain to really ensure that you're generating the value from those components as well. So in engaging in some of these discussions, we reflected on a number of the features of the way deals and data value can be generated, and the different attributes that those can bring to how you consider some of the deals you might be engaged in. And one particular one around data value I wanted to flag particularly for this group was around the distinctions between real world clinical care data versus trial data. There are some very well developed sets of guidance and rules and structures around how IP, data, license and other components are managed through prospectively collected data in trials. And there is a tendency to see those features of deals roll over into the way groups consider how real world data should be considered in terms of value, data ownership and rights. And our experience was that really those need to be considered quite differently, and that that's an important facet to how you're considering the data deals that you might be doing. We also talked with our partners around what different types of deal might look like. So in terms of sort of one-off selling of data to an entity who will then take the data and progress something internally with their R&D, versus a more partnership-based model of co-creation of solutions, and how those deal features may again alter how one would consider the value of the data itself, and how that might be a component rather than a central feature of the deals we were engaging in. Again, through the discussions, what became apparent was that there were a number of potential value levers that might be considered in terms of how one considered the deals one was engaging in, and making sure that all of those were considered as part of the negotiations. To support that work, we also developed case studies looking at how one could consider different features or attributes of deals to support those discussions. So we developed some decision-making trees with Future Care Capital as examples to work through with stakeholders, looking at, for example, in this case, retrospectively collected clinical care data, and whether the features of whether it had been curated, cleaned, annotated in any way, and by whom, and how this might alter the way one would consider requests from commercial third parties for in periods of embargo or exclusivity, or how one could consider that that may well be inappropriate. As I say, we also talked about prospectively collected data within the context of a trial, and then in those sense, what might the value back to an NHS trust for their involvement in such studies be? And is that money as direct staffing costs for the delivery of the study? Is it above and beyond that? Or is it other in-kind benefits that can be generated as a consequence of the new insights? And really, we've tried to assess those different decision-making trees to get the different perspectives from our stakeholders about what were the important questions to be asking to help refine the thinking about what a good deal looked like. So as I said, we talked about a number of value levers. A lot of these won't be surprising, but I think it's important that we consider all of these rather than focusing purely on the commercial or financial benefits of data deals, which is where a lot of the advice and guidance to date have been. So if you can bear with me, I'm going to use the analogy of a sound mixing board. So we can think about how we can dial up or down the different levers. And please ignore the numbers on these. This is purely used as metaphor. It's not in any way scientifically rigorous, but we can think about how we can move through these different kinds of value, ramping those up and down to get a holistic view of a deal overall. So sitting at the heart of all of the perspectives from our different stakeholders was the patient benefit as being the cornerstone of all of the ways that deals should be considered, and ensuring that the data that was being provided was going to generate back benefit for patients either directly or indirectly. And our patient and charity groups often consider this as a form of donation by patients to help future patients. So they weren't looking for direct benefit back to them, but saw this as a contribution they could make to support future patient care. And this may look like something directly in terms of local patient benefit, or more broadly across the NHS ecosystem. It was considered distinct, though, to NHS system-wide benefit, so how innovations could be seen to improve care locally in terms of either cost savings, or generating further revenue streams, as well as national impact across the NHS as a whole. As I say, there was obviously discussion of financial benefits, and there's been a range of publications around how one might consider financial returns back for partners, including as simple as cost recovery for time and resources, through to licensing or equity stakes. Or one that came up again across a number of our stakeholders was the value of price reductions to the NHS for solutions that were being generated. And again, ideally, value that was being seen across the NHS as a whole for these solutions that had relied on NHS data. Given the nature of some of the work we're involved with, academic benefit out of the data deals was also discussed. So the potential for new publications, new research activity, as well as new grant income was one that was seen as being a feature of how deals might be considered. And then one that came up repeatedly with our NHS partners was the potential knowledge exchange benefit. So this was focused more around partnership deals where there was an exchange of expertise, training, or in-kind contributions, which had value back to the NHS, which were not direct financial ones, but were going to improve workforce performance, were going to improve retention, were going to help keep those NHS trusts as cutting edge. On the side of the company and industry partners, obviously there's the end of economic development benefit, which is one that, again, being funded through Innovate UK, we are interested in. So how can we support UK companies' growth with subsequent increases in tax revenues for the government, which could then be reinvested back into the NHS to improve cost services and delivery of care. Also, the potential for further investment in jobs and companies and future R&D as all being mechanisms by which the data could enhance benefits back to the UK as a whole. And finally, not all data was seen as being created equal, that there was reputational benefit for engaging with certain types of partners in terms of brand profile, international reputations and quality, as well as trustworthiness, and that this idea of brand as being a marker of value was something that was implicit, but I think needs to be factored more into how deals are being structured. So these are some of the variables at play for us to be working with in terms of how we might structure deals that we're doing with partners. But still, there are some observations about where we might need to take this further. And that really considering that there are both deal and data characteristics which could further inform more detailed decision trees, and that the priority value levers of different partners need to be considered to achieve a deal that has value that's not left on the table. Again, I've mentioned sort of the difference between one-off transactional rather than longitudinal partnerships, and that partnerships may be where there is real value to be generated for all, and that the data itself is simply an enabler of the partnership rather than being the core component. And then again, the sense that the ecosystem as a whole is not well understood, particularly by patient groups, and that the roles of industry in supporting translation and impact for patient care was not well understood, and this is an area that could be further developed. So where next? The landscape's got more complex rather than less so, which means it's hard to think about how we continue to apply this post-COPE and post-Brexit. But within NCIMI, we're trying to use this to consider how we're structuring the deals we're doing and using those value levers to be considered as principles for all of the data access requests that come for the data we hold in our data bank. And that this is a bespoke and quite resource intensive way of approaching this, and each deal is considered differently. But to scale this nationally, do we have to simplify it? So does this become one size fits all? Can we keep bespoke, or is there some middle ground of archetypes? And could we consider the usual suspects? So the NHS partners doing deals between themselves, with academics, with SMEs versus global players, versus multi-stakeholder partnerships. And could we further develop archetypes and decision trees to support those arrangements and provide some base templates for partners in the system to be working with? So that's something we'd like to see further exploration, both within NCIMI and nationally, to support us developing something that reflects the complexity and in fact embraces it, but realises that beyond the principles that have been provided, operational delivery requires more detail and practical tools to actually enable us to do the work. And that in the UK ecosystem, the partnerships may be the critical component for realising the value of the data rather than the data asset itself alone. And so I sort of wanted to conclude just by saying that we within NCIMI think that the partnership and collaboration with the clinical expertise and insight and the drive to work together and embrace the complexities in the system is what will release the value locked into health data for imaging. Thank you.
Claire, thank you so much for that. That was excellent. And it's given us a really nice overview of the various frameworks that really should be considered for any sort of partnerships that NHS trusts engage in, as far as I'm concerned, because some of the things that I've personally come across is that in the eagerness to join and collaborate, and in the spirit of eagerness, which is always very good, NHS trusts may well be losing out because they haven't looked at what value they're going to derive, whether it's improved patient outcomes or actually financial outcomes in terms of investment for time and resources. What's your experience been generally on the back of this framework evaluation?
So I think it's been, so on the one hand, I feel like we've learned some really interesting things. And on the other hand, as I've said, it's not rocket science, the types of value that we pulled out from the discussions. I think what's been interesting, though, is that those values didn't sit within just one entity. So they were expressed across the piece by commercial parties and by NHS stakeholders. And so if we really do want to do collaborative co-creation, it's being able to have those frank conversations about what is really important and thinking about who the relevant stakeholders should be at the table. So if you're negotiating with the CFO of a trust versus the director of R&D, you could get quite different responses to some of the things that they consider important. So in terms of advice to NHS Trust, I would suggest forming groups to think about what your value levers are and how you want to apply those and who gets a voice at the table for then having those negotiations.
That's excellent. Thank you. And we're getting quite a few questions, Claire. So at least 3 of those questions are about collaborating with NCIMI, whether you're an NHS trust or an SME. If you would help them out with that.
Yeah, so we're certainly open. We're not a closed shop. We've got a diverse network of hospitals, and we're open to both supporting new projects with industry partners as well as bringing in new NHS partners. Amrita, you work with us, so you can give people your experiences as well, but we're certainly not closed off. And what we are, again, trying to support is collaboration with initiatives like NHSX's AI lab funding, so that we can provide a vehicle for then delivery of some of those studies. So if people want to get in touch directly, my email address is available, but do get in touch and we can have those conversations.
And I suppose, Claire, it's also good to point out at this point that if they also just type in NCIMI, they will go to the website, which has further details.
Indeed, yeah.
Lovely. And can I ask one more question from my side, that do you feel that when it comes to actually looking at the value levers more towards the financial end, that obviously historically, and by historically I mean in the last year or two, there has been, no one's really looked at it when approaching NHS trusts purely because maybe there was a sort of not an equal partnership considered, whereas I feel a lot more that at the current time, whether you are industry, whether you are academia or an NHS trust, there's equal partnership with the equal importance of all of these stakeholders, so that there's more open discussion about the value that each person brings, not just the computational power or the...
Absolutely. And I think there's potentially been some overhyping of this as well. So I referenced the £9.6 billion per year figure. I think that certainly got NHS Trust CFO's attention in terms of realising, appreciating they had an asset that was potentially being undervalued and more needed to be made of that. I think there's a risk we swing too far the other way and that data becomes something that gets locked up within organisations because people want to optimise financial value. And what still doesn't really exist is guidance of what the financial value is. And I didn't focus on that particularly in the talk because I'm not an economist. It's not something that we've tackled, and it's not something that I think anybody globally has established a good, strong foundation for. So there's a little bit more to be done in terms of seeing what good might look like and letting some more deals happen to develop that in more detail. But yes, I think there is certainly a more equal appreciation of the value of data than there has been historically.
Thank you. I have one more question. Do you have any international collaborations currently?
So not in terms of clinician sort of healthcare professional environments, but in terms of companies, yes. So we are working, so GE is one of our partners. We're also working with Roche, Lunit, Icometrics based out of Europe. So we're not UK focused in terms of support for international innovation at all. And really sort of keen to, again, support further collaboration, which I know Geraldine's going to talk a bit more about in a minute, but I think it's critical that we work across geographies to actually deliver the most impact.
I couldn't agree more. No, thank you so much, Claire, for going through that. That was very, very informative.
It was my pleasure. And yeah, if anybody wants to get in touch afterwards, then just please drop me an email.
Thank you, Claire.